Hey guys, I hope you're keeping safe. This is Dr. Marwah, and today we'll be talking about MCQs of the recently conducted CET November 2021 exam. Let's start with the very first one. It talked about a hypertension patient with hypokalemia and metabolic alkalosis. Option number A talks about Gentleman syndrome, which I can rule out very easily because this would be a definitive problem in the distal convoluted tubule, and if the sodium chloride co-transporter will malfunction, this condition will be having salt wasting, and therefore the blood pressure of the patient will never ever be elevated, rather it can be normal to low. Same, I can also rule out Bartter syndrome because Bartter syndrome is based on the defect in the thick ascending limb of loop of Henle. The transporter which is defective here is the sodium potassium chloride co-transporter. Option A and C, both of them are characterized by salt wasting, so cannot have a high blood pressure. I'm left with two options, Liddell and Gordon. I'll try to solve this MCQ two ways. One is the straight way, second is by exclusion. So let's talk about Gordon. Gordon, though I've discussed in the Mendelian causes of hypertension, Gordon syndrome has been discussed, and this is characterized by gain of function of the sodium chloride co-transporter. Now, because of the gain of function of sodium chloride co-transporter, definitely you can be having is a hypertension, but along with this, the electrolyte imbalance which is present here is hyperkalemia. So next time if you get a question in the exam that talks about a hypertension patient with hyperkalemia and even a hyperchloremic acidosis, then you have to answer it as Gordon syndrome, which I think will be a future question. And this one anyway was relatively an easy one and has been even asked in the NEET exams in the previous year. That is going to be Liddell. So let's have a quick look at what's the problem in Liddell. In Liddell, there is no problem with the hormone. It is gain of function of the epithelial sodium channel. Now, if this is going to work more, you can very well see that there's going to be more salt and more water coming in the body. That will explain the high blood pressure. But there's also going to be a urinary loss of two things, potassium and hydrogen, and because of this urinary loss, the blue arrow and the marking that are done right now, you can be having a presentation of hypokalemic metabolic alkalosis. So answer to question number 1 that we're going to discuss here is option number B and can be solved both on the basis of exclusion as well as a straightforward answer, and most guys were able to answer this since it was a relatively, I would say, an easier one. The next question talks about a patient of resistant hypertension. Now, he has already asked regarding the definition of resistant hypertension, which is primarily because of non-compliance or maybe because of faulty measurement by the healthcare physician. But this definition has already been asked. I mean, how many classes of drugs? That is 3 classes of antihypertensive drugs. So what he did was simply that he modulated the question and he said which of the antihypertensive drugs must be included in the trial before you say that, okay, the blood pressure of the patient is not getting controlled. As I've highlighted, the simple and the straightforward scenario for this would be a good trial of thiazides. The answer to this question would be option number delta, and if he asks in future, I mean the trial should be at least for a minimum of how many days or weeks or months, then the trial should be at least for 2 weeks. Like you have given ACE inhibitor, no control with ACE inhibitors, max dose over 2 weeks, you add CCB. If the combination is not working, you wait for 2 weeks, add then subsequently diuretics, and if the 3 of them are not working, then you definitely need to consider 2 basic fundamental problems. One is going to be faulty blood pressure management. It could be a patient who has bought a digital sphygmomanometer and he's measuring his blood pressure at home and it is coming out to be falsely elevated since the instrument is faulty. Though they are standardized, I'm saying a poor quality brand can definitely have a false elevation present in the values of the patient, or for that matter of fact, it could be simply that this guy is non-compliant with his medication. So these 2 factors have definitely to be ruled out before you start considering rare causes for hypertension of these patients. So there were 2 questions on hypertension which I have solved before you. Let's move to the next one. This talks about a chronic smoker who's presented with shortness of breath, pedal edema, right upper abdominal pain. So the presentation of pedal edema, right upper quadrant pain, which is somewhat telling you that there could be a tender hepatomegaly in the patient, tells you that the right side of the heart is involved. However, why there is a shortness of breath, then I'm not talking about pulmonary edema at the moment. You very well know that a smoker can be having COPD. COPD in the long run can cause pulmonary artery hypertension. And if anybody is having pulmonary artery hypertension, the pulmonary blood flow will be reduced. If there is less pulmonary blood flow will contribute to development of shortness of breath in the person. So you don't necessarily need to have a pulmonary edema component only to contribute to shortness of breath. On general physical examination, elevated JVP, again a feature of right heart failure, liver palpable 8 centimeter below the costal margin. So everything given in the question was talking about right side of the heart getting involved. And according to some of the students, there was a cadaveric image of the heart also given, and it was simply you had to mark which chamber of the heart would be involved in this case. So the answer in this case would be pretty straightforward, the right ventricle. And you will notice that the previous NESAT exam that would be conducted in July, what happened was that he gave a similar question, but one issue with that question was that the image of the cadaveric heart that was given was actually switched the other way around. I mean, instead of showing the heart the way it is, anatomical position anteriorly, they had shifted the position, because what students could make out was a interventricular sulcus present posteriorly. And then obviously you had to adjust a bit and answer the right ventricle on the contralateral side. I mean, why I'm saying that is primarily because this is where anatomically speaking the left ventricle should be, because the heart position was inverted in the previous NESAT exam. Then a right ventricle to be figured out. I mean, some guys had a problem. And another issue in the previous times MCQ was that he had also mentioned regarding systolic murmur on the left hand side. Now, when you read about systolic murmur, the first thing that comes to your mind is it can be mitral regurgitation also, though my point is tricuspid regurgitation will also contribute to a development of a systolic murmur in a patient. So yes, the question that was asked in the previous session had a bit of a flaw, and this time they refined the same question. I mean, everything was same, the language, the chambers of the heart getting involved, but at the same point of time they had refined the question, so most guys did not face any problem while solving this one. The answer is A. We move to the next one, which you will notice that they have started rather asking more about aspects of when would you use novel oral anticoagulants, and this is one such question where you need to understand should you be using a novel oral anticoagulant or not. And it's I would say a carryover from the previous NESAT exam only. So I'm sure that if you would be watching them in sequence, I mean for 2021 you were watching first the July paper and then the November, but even if you started with the November one, no issues. Let me just explain this to you. He said an old man with severe mitral stenosis has presented in atrial fibrillation, which will obviously contribute to twitching of the heart. So there would be clots that would be formed, and these clots will move on to the brain, and therefore transient ischemic attacks will occur. He says, which of the following statements would be correct for prevention of stroke? So A said only aspirin is to be given. You see, the bottom line is whenever you read about atrial fibrillation, whenever you read about clots, you always read about warfarin or a combination of warfarin with aspirin, but never aspirin alone. You see, for a TIA, it is okay. You see, when I have described transient ischemic attack with respect to, let me say, atherosclerotic lesion in the carotid artery of the patient, I can be definitely thinking, okay, man, this chap could be having a atherosclerotic lesion in the carotid artery, the emboli which are going into the brain, so I need to anyway use aspirin. But for a documented case of atrial fibrillation, he who is having mitral stenosis on the long run, that too of a severe variety, alone aspirin is not given. And I'll just zoom into this image from Harrison here, where he has mentioned regarding a combination of the two, and aspirin alone is not given. It's either an oral anticoagulant or it's going to be a combination. So when you look at option number A, I'm going to strike it off. I'm going to rule it out because alone it's not going to work if you have a documented atrial fibrillation with severe mitral stenosis. Plain TIA events, yes, aspirin and even clopidogrel dual antiplatelet therapy has a role. B says warfarin would be given in prevention of stroke. That is okay. Dabigatran does not prevent stroke. Now the bottom line is they have picked this up directly as a line from Harrison, so I'll just zoom it in for your convenience. He has said the newer directly acting anticoagulants have not been tested in patients with rheumatic heart disease, which is one of the very important reasons why severe mitral stenosis can be developing in an Indian patient. And well, why is that so? Is because the risk is too high for a person to be tested for this newer category of drugs. And apart from this, I mean, we do not use the novel oral anticoagulants also in patients who are having mechanical heart valves, and both these aspects have been asked. So I thought I'll just show you the reference from Harrison for the same as well. So option number C is definitely the correct one, as I showed. Dabigatran does not prevent stroke in a sense that it is not used. So that's why, I mean, this statement is okay. D says mitral valvectomy is an indication for prevention of stroke. Now for this, if you have sat for the paper, I definitely would like you to give me an input, also on my email, that's marwahmedicine@gmail.com. Was it mitral valvotomy is an indication for severe, that's a procedure that is to be done with a person of severe mitral stenosis, or was it mitral valvotomy is an indication for prevention of stroke? You see, if I say percutaneous mitral balloon valvotomy or a mitral valve repair or even a replacement is needed in a chap who's having severe mitral stenosis, it is okay. But if it is written for prevention of stroke, then changing the valve and thinking of preventing stroke would be, I would say, a disaster in making. Why? Because there are some clots which are already present in the left atrial appendage of the patient thanks to atrial fibrillation. Now, in a patient of severe mitral stenosis, the orifice is small, so the chances of clots going into the systemic circulation from LA to LV and then into the brain will be still relatively lesser. But if you're going to do a balloon valvotomy and you restore the diameter of the orifice, get the mitral valve back to its usual original glory, then because the orifice is bigger, the chances of clots going to the brain will be increased. In fact, to give credibility to this point number D, why did I rule it out? I'm also going to show you a reference from Harrison which says the same, that whenever you are planning a mitral valvotomy, you must document that there is no left atrial thrombus by doing a transesophageal echocardiography in the patient, because let me say, you were trying to do good for the patient. But the basic essence is first do no harm to the patient. You were trying to do something good, but the bottom line is if there was a thrombus present and you dilate that opening, the chances of that clot going into the brain and the person developing a catastrophic stroke of a big artery like a middle cerebral artery can definitely happen. So in this particular question, option number B and C definitely make sense, which is the reason why I have given option number 2, where B and C are correct, as the correct answer to this question. Coming to the next question, which was very widely debated, the question said a cirrhotic chap is having ascites and which of the following can be used to mobilize the edema fluid. So traditionally what we're going to do is we are definitely going to use spironolactone for the patient. Now the point is that spironolactone can contribute to development of painful gynecomastia. So instead of letting that patient suffer from that, I would say not only the physical issue of it that he's having a gynecomastia, but the pain component as well, I would like to switch him over to eplerenone. The correct answer for this question would be option number beta. And I know you will say, sir, why not option number A? Because furosemide is also given in patients of ascites. The points that I have are that if the question mentioned the word refractory ascites, or if he mentioned, let me say, massive ascites, tense ascites, or even said that the person is having ascites to the level that it is causing respiratory or breathing difficulty, then if those prefixes were present in the question, I still would have thought in terms of furosemide to be given in a person, but this would not be a permanent solution because you do not give furosemide on a very long-term basis because of obviously the hypokalemia component that would set in. So I think that the basic logic behind this particular MCQ will be that because cirrhosis can contribute to development of gynecomastia, and this is very clearly given even in Davidson, that because these patients would anyway be having higher levels of estrogen, and spironolactone is anyway known to contribute to development of painful gynecomastia. So I would like to use a better drug from the pharmacological perspective. You very well know that eplerenone does not contribute to gynecomastia, just like spironolactone would, because of which I would say that option number B will be more suited for an answer for this question as compared to furosemide. And furosemide, there are two reasons which I want to repeat once again. One is the big problem of hypokalemia, which would be seen with prolonged usage, because for ascites it's after all gonna be a long struggle. I mean, it's not that one off medicine that you're gonna give to this chap for, let me say, 5 days, 7 days, 10 days, and he's gonna be fine. I mean, I will have to go in for salt restriction and usage of aldosterone antagonist on a long-term basis to prevent the reaccumulation of ascites in these patients. And yes, once he goes into refractory ascites, then the usage of furosemide makes relatively more sense. So the answer to this question should be given as option number B. The next question has a pediatric overlap. He said congenital heart disease with equal saturation in all the chambers of the heart. So what I thought was, like, you would be having about 1 minute for this kind of a question. So let's try to at least say that in the first attempt, I should be able to rule out at least 2 options in this question. So let's look at option A, tetralogy of Fallot. You very well know what I did was I just hand drawn them before you. What I've shown here is a subpulmonic stenosis, not pulmonic, subpulmonic, obviously a VSD. I've shown a concentric right ventricular hypertrophy as well. So at least three defects can be seen at the movement: subpulmonic stenosis, RVH, and definitely a VSD. Now in this particular patient, anyway, oxygenated blood will be coming in the left atria. So the way I put the red arrow and I'm putting it once again, you can very well see saturation can never be equal in all the four chambers of the heart, because this is oxygenated, this is definitely contralateral side deoxygenated. I agree there's going to be mixing in the ventricular chambers, but at the same point of time, the oxygen concentration cannot be same in tetralogy, phylat, and even in transpositional great arteries. See the diagram that are drawn for transpositional great arteries, the aorta is originating from the right ventricle of the patient. As a result of this, the deoxygenated blood is circulating in the body and the oxygenated blood from the lungs is circulating in the left side of the heart. And because you are having two parallel circulations, the saturation in the two chambers, left versus right, would be grossly different. So two options can be ruled out very easily. Now let's look at tricuspid atresia, the line diagram. In tricuspid atresia, hardly any blood or no blood will go in the right ventricle. Why? Because the tricuspid valve is atretic, and even if they have a VSD present, the amount of blood going into this would be relatively lesser. So the way tricuspid atresia has been drawn before you, you can very well see the fact that most of the time, how's the blood gonna go towards the lungs? I mean, if I remove everything here, how's the blood gonna go in the lungs? Just look at my line diagram. This mixed blood will travel down into the aorta. Via the ductus, it's gonna come into the left side of the heart, and therefore, I mean, it will come to the lungs and then will come to the left side of the heart. So the bottom line is that the right ventricle per se is not a part of the circuit. The lungs are directly being fed via the ductus arteriosus, which you will try to keep patent by giving alpostadil. But again, the concentration of oxygen in the chambers, when you compare left versus right, because left as compared to right is functionally not working, would definitely be, or even if there's a small VSD present, the concentration is not going to be the same. But if you look at the last line diagram that I've drawn before you, I have shown is the cardiac variety of TPVC. The green here is actually the abnormal blood vessel. This aberrant blood vessel is sending oxygenated blood into the right atria. So you can see oxygenated blood in the right atria will then be going into the left atria via the patent fossa valis and will be going into the right ventricle anyway. So ultimately what you're seeing is, in this particular diagram, right atria per se is gonna be supplying this oxygenated blood to the patient's left side as well as to the right hand side. So total anomalous pulmonary venous connection from the line diagrams that I made before you makes more sense here. Otherwise, I would say I would rate this as a difficult question, because this is one line that is given in Nelson textbook of pediatrics, from where he has tried to pick up and create a question for this exam. And from the line diagram, I've tried to just highlight this. And in fact, I have discussed congenital heart diseases in the main section in the app also. So I know you have read it from pediatrics, but I would request you to just listen to my discussion also, which I think the line diagrams that I've drawn will give you a much more faster. I mean, I know you're good at it, but it will help you interpret the data relatively faster. Moving to the next question, he says, what is the management of an acute attack of cluster headache? Then the logic to be understood is that this chap, when he comes to you, he says, sir, I feel as if somebody is drilling a hole in my eye with a drill machine. If a chap who's having a migraine variant, which is going to be so excruciatingly painful that he's going to say, I feel as if, I mean, somebody is boring into my eye with a drill, then you need to ensure a quick relief. The initial management of these patients, the MCQ, I chatted with a lot of guys who cleared the exam. All of them said, sir, the question did not say what is the initial management. Initial management is obviously high flow oxygen. 12 to 15 liters per minute. You can also instill lignocaine jelly into the nostrils of the patient to anesthetize the trigeminal nerve endings. And meanwhile, you can give the drug of choice, which is the sumatriptan shot. So the answer in this case would be option number delta. And I would say that I could have used a nasal spray also, but because these patients would also be sometimes be having a lot of epiphora, watering from the nose as well. So I think that as compared to nasal spray, giving an injection with such a excruciating, I mean, this is one of the most, I would say, severe pain syndromes that you're going to encounter in your practice. And some of these people even develop psychiatric manifestations. They might take a pointed object, and I'm going to say extreme thing, he might try to hurt his eyeball. he will say, sir, I feel as if I puncture my eyeball, the pain will lesser. So that kind of aspect where somebody is going to hold a pointed object and is going to try and hurt his eyeball, that's pretty extreme, right? Kind of a behavior. So we might have to even start lithium in these patients. And anyway, I've discussed cluster headache in the headache chapter, so you can go through that. The next question was a setter, I would say one of the easiest questions in the exam. Which wave the JVP contributes to the isovolumetric contraction? You can very well see the bulge of the valves occurring upwards, which would be contributing to the presence of the C wave. So this is pretty straightforward. The answer to this question is Bombay. Moving to the next one, which you see there was a shift, I would say gear shift by the examiner. I mean, after putting such a straightforward question, that you start asking yourself, is this really a any set based exam, central institute based exam? He just changes the game diametrically. He says, which of the following is a true statement? Option A says scalp EEG is diagnostic of frontal lobe epilepsy. Now my point is, EEG is obviously a good test, but EEG will pick up findings only when the person is having an episode, no? If a person is not having an episode, EEG can be normal also. In fact, most of the time, focal lesions can be missed by a EEG as compared to a GTCS. And just to give credibility to why option number A is not a correct statement, let us zoom in into what Harrison says. And I'm just going to underline this data. He says focal seizures may not be detected by standard scalp electrodes. I'll repeat that again. Focal seizures which may originate from different areas of the cortex may not be, is written cannot be, or I'm saying may not be, cannot be detected by the standard scalp electrodes. And apart from this being a limitation, I said if a person is not having an episode, you may not be able to get a proper electrographic diagnosis, and therefore option number A is not a correct statement. B says 10% of healthy people have epileptiform waves on EEG. This is definitely, I mean, one, epileptiform does not mean that he's going to have an epilepsy. It just means that you could be having spikes. You could be having polyspikes in the EEG of the patient. So epileptiform word looks very dangerous, like, you know, somebody's just going to end up with epilepsy. This is just a description of a pattern. Pattern would mean that there are some spikes present or polyspikes present in EEG of a patient. The data which is given is most of the time in the range of 1 to 5%. So all I think is option number B is, I would say, correct and partially wrong. I'm just giving it a benefit of doubt. I'm writing plus minus here. Why? Because the only problem with this statement is 10%. It's a little on the higher side. I mean, majority, if you say that 10% of the world population is going to have a discharge in their brain which is identical to that of an epileptic patient, looks like a little, I would say, outstretched statement, a little exaggerated statement. So I would like to keep it still on the back burner. I mean, still in my mind, maybe a correct statement. Let's read C. EEG is not mandatory for diagnosis of epilepsy. Guys, I've highlighted, there's a separate video where I've actually shown on the channel, and it's also present in clinical essentials part, where I have demonstrated in patients the various types of epilepsies. And I just want to highlight the definition of epilepsy would be 2 episodes of seizures, that would be unprovoked seizures. For diagnosis of epilepsy, there is no requirement of any EEG finding to be documented. I have a Harrison reference here, 2 or more unprovoked seizures, that's the definition of epilepsy. I also have the definition from the International League Against ILAE definition per se, and it says the same thing. I mean, obviously, if it's a epilepsy syndrome, right? If I say epilepsy syndrome like Lennox-Gastaut syndrome, EEG findings will be present. So I do not dispute the fact that when you have a epilepsy syndrome in a person like Lennox-Gastaut syndrome, you definitely are gonna find some specific EEG findings in a patient. But that does not mean that EEG has to be always positive to call somebody as an epileptic. Lots of time in your OPDs also, you might be starting somebody on medication, though his EEG report is normal, because EEG was not done at that particular point of time when the episode had occurred. So this looks like more of a correct statement. So just put 2 plus signs here. Let's read D. Progressive multifocal leukoencephalopathy. For this, all you need to remember is, when do you get progressive multifocal leukoencephalopathy? So this can be found in AIDS positive patients, or I would specify a person who has not taken treatment for HIV and has deteriorated into AIDS. So what I'm going to do in this patient is, I'm going to take the CSF. I mean, I'm going to perform a lumbar puncture and take out the CSF. And then on the CSF sample, I'm going to do a PCR, by which I'll be able to determine the JC virus DNA. So the best test to confirm that somebody is having a progressive multifocal leukoencephalopathy which is caused by JC virus is to go for a lumbar puncture. Another technique that I can go for these patients identification is leukoencephalopathy. There's a white matter involvement here, so therefore I can say MRI will help. Even if I do EEG in these patients, most of the time, because there would be a neurodegeneration, ultimately in these patients there would be a suppression of the EEG waves instead of a generalized epileptiform waves, or some people said polyspike pattern present. I mean, to have multiple spikes present in the EEG of these patients considering neurodegeneration, because ultimately this person is gonna have even developmental deficits like aphasia, apraxia. Though it takes time, that's okay. I mean, it's a slowly developing process, but because cortical involvement is present, so in these patients there is a gradual damage, and the damage would ultimately contribute to cortical slowing and not presence of epileptiform discharges. So I have ruled out two options in between B and C. One is more correct as compared to others. So I would rate this as a much more difficult question than the previous one. The correct answer for this question would be option number C. The statement is EEG is not mandatory for diagnosis of epilepsy. I mean, you just need to demonstrate 2 episodes, unprovoked seizures, and they must be at least 24 hours apart. Why 24 hours apart? Because they're going to occur in the first 24 hours, or if they're going to be very close together, 6 hours apart, it could even be a presentation of GCSE also. Generalized clonic status epilepticus, you could be having multiple episodes in a single day as well. So that's why that gap of 24 hours has been kept in the definition or in the image that I showed before you. The next question said hypoxia with a normal alveolar arterial gradient. Normal alveolar arterial gradient is 5 to 15 millimeters of mercury. Capital A basically means the pressure in the alveoli, and small a would mean the pressure in the blood vessels. So I'm going to describe, before I give you the answer, I'm just going to describe a patient with status asthmaticus. There is a airway shutdown. If there's an airway shutdown, then capital A will also decrease because air will never reach the alveoli. If somebody is having, let's assume, somebody is having silent chest. I mean, asthma attack is so bad that there's an extreme amount of bronchospasm. So if air is not going to go inside, capital A will also become less. If capital A will be less, even small a will become less. Now let's put some mathematics here. If capital A decreases by, let me say, 5 points, and small a also decreases by 5 points. If mathematically speaking, both of them are going to decrease by the same magnitude, it's not going to affect the mathematical value, and therefore the gradient will remain normal. And this is going to happen in those patients where there's going to be presence of a hypoventilation. And I have described this alveolar arterial gradient in the spirometry discussion as well. So please definitely go through it. I mean, when I say normal, it's going to be a type 2 respiratory failure. And when it's going to be increased, then what's happening is only the small a will become less. And that could be like tetralogy, pilot, or COVID-19 pneumonia. Because if somebody is having COVID-19, there would be a presence of a I would say interstitial pneumonia in a person. Like in COVID-19, there would only be presence of interstitial pneumonia in a person. So all it will do is reduce the small a component, but the capital A component will remain the same. Therefore, the correct answer to this one is option number A. All other aspects which are mentioned, I mean B and C, they both are ultimately the same. I mean, if I say alveolar membrane damage, that would be COVID-19, for example, and that contributes to ventilation perfusion mismatch in a patient. So small a will become lesser. Right to left sided shunt will rather cause an increase because only the small a component is becoming reduced. The next question said, which of the following drug is the only medication useful for preventing progression of disability in primary progressive multiple sclerosis? You are very well aware of the fact that the most common type of multiple sclerosis is relapsing remitting variety of multiple sclerosis, for which we have multiple ways to handle it, like beta interferon and glatiramer injections. But for primary progressive, you will notice that till I would say 2018-19, we really did not have anything really very substantial to manage these patients, and the prognosis was really bad. But you will notice that currently in the books they have mentioned, and I have also done that right at the fag end of the multiple sclerosis video, you will see me talking about ocrelizumab, which is useful for management of these patients. So the answer to this question is option number Bombay. I mean, sometimes last line in the entire video discussion can even be asked. The next question is from endocrinology. He said, which of the following is not gonna be seen in a patient of SIADH? Now, SIADH anyway would mean that there would be increase in the total body water amount. but the total body salt would still be normal. So body water is more and salt is going to be normal. This is definitely going to contribute to a dilutional component coming in, which explains the fact that why option number A is a correct statement. Hyponatremia can be present. But at the same time, because body water is more, that does not mean that he's having hypervolemic hyponatremia. I have explained in routine videos also, for having a hypervolemic, you should be having more total body water and total body salt should also be increased. If both things are increased, here you can see only one thing is increased. If both are increased, you call it hypervolemic hyponatremia. But if only one thing is increased, you call it that is total body water. Obviously, because dilution component has to come in, so you would be calling it a euvolemic hyponatremia. So two options are sorted. We are left between option number B and option number D. Urine osmolality is increased. Well, it is straightforward, because you see the V2 receptors will have to do more work, so all the water will come back in the body. Water will come back in the body, urine will become concentrated. And some of the people mentioned that, sir, the urine osmolality values were given more than 100 milliosmoles. I don't have no issues with that, because normal range is 100 to 900 milliosmoles. So obviously, at least this is fitting into a normal value. I mean, I can say the fact that it may not be grossly increased, but yes, it is fitting into a normal value initially. So option number D definitely makes sense. Why? Because water is coming back, so urine will be concentrated. We are not to focus on the mathematical values, because in early part of the disease, the values could be fitting into normal range as well. But let's look at option number B. Now we have figured out the answer is option number B. But what happens in patients of SIADH is that because there's going to be more water in the body, this is going to contribute to development of natriuresis. And this natriuresis causes the urinary sodium in these patients to be usually in excess of 20 millicolloids. So I want you to remember, I mean, values are secondary. I don't want you to cram values. I just want you to remember, why is urinary sodium increased in these patients? Because the logic is, after all, this disease is all about water reabsorption. We are not talking about salt per se. We are not talking about aldosterone. But still, in this case, I'm not saying that there is gonna be salt wasting occurring in this patient. What I'm saying is there's a natriuresis component coming in, which explains the fact that why there could be increase in urinary sodium of these patients. And this is one of the important diagnostic criteria, and is in fact a repeat question. The answer to this question is Bombay, and I would request you to listen to the discussion of Liddle-Bartter syndrome, diabetes insipidus, SIADH. In a single video, I have discussed 4 diseases: Bartter, Liddle, Gentleman, and obviously they love to talk about this disease. And you can very well see now the very first question that I discussed with you, and this time when he said was Liddle syndrome, and then they asked about SIADH. So from the same video where I have compared the diseases, you can see if 2 diseases are coming, you definitely need to give the due importance to that particular video per se. So if you're using an alternative source, no issues, but then listen to Bartter, Gentleman and SIADH, diabetes insipidus, in a comparison. If you're going to listen them in isolated fashion, you will never be able to compare them. So on a comparison basis, I mean, as I have discussed in a tabular format, it will relatively make more sense before you, including aspects like psychogenic polydipsia, and then even as I would say adipsic hypernatremia. So please go through the SIADH discussion. This is given in the kidney part along with Liddle and Bartter syndrome. The next question was regarding hepatitis B serology. And students after the exam told me, sir, everything was given to be negative. The only thing positive was immunoglobulin G antibody to the core antigen. Everything else was negative. Now let's look at the options. I'll start from bottom. Window period. Window period is when IgM class of antibody to the core antigen is the only thing present in the blood, whereas in the exam the IgM class of antibody was negative. I agree, everything else was negative, but IgM class of antibody, the main determinant, was negative. So option number 4 can be ruled out. Option number 3, a lot of chaps were saying, sir, why not 3? Pre-core mutant, that looked like an answer. I agree that in pre-core mutant, which is more common in Russia, which is more common in CIS group of countries, the former Soviet Union or USSR as they used to call it, but then pre-core mutant will not express E antigen. Because it will not express E antigen, you as a doctor will not be able to pick out that whether it is replicating or not, because E antigen is anyway indicative of replication as well as infectivity, but at least it will be expressing surface antigen, no? So what I have shown here before you is a Government of India document which talks about the interpretation of serology tests in hepatitis B, and for pre-core mutant is mentioned that surface antigen will still be present. Agreed, E antigen will be negative. Agreed. But then surface antigen at least will be positive with respect to a pre-core mutant. So this again makes it an unlikely answer for this question. Let's look at chronic hepatitis B. In chronic hepatitis B, anyway, you should be having two things: surface antigen, which was anyway negative, and along with this, there should be presence of IgG class of antibody to the core antigen. So you need at least two things for positive for diagnosis of chronic hepatitis B. By exclusion, you can work out the answer for this would be a remote infection. And if you go to the actual video of hepatitis B, I've spoken about remote, or for that matter of fact, since we are talking about references here, let me show you a reference from Harrison. Let's just have a quick glance at the entries on the top. The first entry is surface antigen, then antibody to the surface antigen. So just get a hang of it because I'll move the slide superiorly. There are 4 entries in this table where surface antigen is positive. And there are 4 entries in this table where surface antigen will be negative. So after all, since in the exam he has mentioned, I'll just, for your convenience sake, just give me a second. I'm writing the word surface antigen once again. This is antibody. This is the protection antibody against the surface antigen, because in an immunized individual, security system will come. So I've just copied the data from the top. Now let's analyze. If you look at the first entry, you can see couple of things are negative, only one thing is positive, IgM class of antibody. That will make it acute hepatitis B, which I already explained. IgM class of antibody was not given per se. Let's look at the last option. Surface antigen is negative, but protection antibody is present, no? Protection antibody के surface antigen is present. So why am I ruling out the first entry and the fourth entry is very well justified, because IgM class of antibody and antibody के surface antigen was not given, which leaves you with only 2 scenarios in the exam. So even if you challenge me by saying, sir, your recall is not correct, my point is, one, I did not give the exam. I spoke to a lot of my students and they are the ones who gave me a recall, and you can notice that everything is negative, but then IgG class of antibody is present in 2 scenarios: recovery from hepatitis B, and then is going to be hepatitis B in remote past or a low level carrier. The bottom line is, how do you differentiate between the two? If somebody has recovered, listen to this part very carefully. If somebody has shown recovery from hepatitis B, then at least the security system will be present, no antibody to the surface antigen. Whereas the report given by students was, sir, there was no antibody against the surface antigen. They did a double check and a triple check in the exam, sir, no protection antibody. As a result of it, the only plausible scenario that was given in the exam was the one that I'm highlighting. So I would like you to take a picture of this component, this part of the table, and obviously, I mean, you will be having this even in your notes as well. I've discussed in the video also, but I think if you just keep a snapshot of this and keep on looking at this table again and again, you will be having much more insight or wisdom into why the answer to this question looks to be from these two possible plausibilities. As I said, hepatitis B, remote past. So the correct answer for this one is what I've highlighted here on the basis of exclusion. And if you still have any doubts on this, or you still have other options beyond these, right? So like some people said, sir, there were 2 options with chronic. I am ruling out both the options with chronic, because for chronic, the fundamental aspect is that 2 of these things should be positive, right? Unless and until he's had a recovery. If somebody's had a recovery, then security system should be present, no? But in the description, everybody was very vocal about the fact that there was no mention of the security system, antibody against the surface antigen, which results in answer being A. So this question can obviously be debated a lot, but if I think you can have a look at these 4 possibilities of positive surface antigen, 4 for negative surface antigen, and analyze them one in a day. I mean, don't try to analyze the whole table in a single day, it will become too much. So try to divide the table into 2 parts, and if you're gonna have a look at that, you will be much more comfortable in analyzing and remembering the information. Now for the next question, all I can say is I can draw some geometrical shapes before you, and if I say, doctor, can you draw them? Obviously you can look, you can analyze, you know it's a triangle, it's an inverted triangle, it's a star. I mean, I don't need to describe the geometrical shape before you. You can look, analyze and draw. This is a function which is with respect to the parietal lobe of the brain, pretty straightforward. And this is damaged, and I've discussed that the person would be having constructional apraxia, which is a very characteristic feature of damage to the non-dominant parietal lobe. So the answer to this question is well documented by the clinical deficit that will also occur in the patient. Coming to the next question, he talked about a patient with class 2 pulmonary artery hypertension in whom the vasoreactivity test was negative. And believe me, he tried to make this question look like rocket science by talking about vasoreactivity test. What you mean by vasoreactivity is very straightforward. You give the person inhaled nitric oxide, and if he's gonna be responsive to this inhaled nitric oxide, then the mean pulmonary artery pressure will definitely come down. No? If this does not happen, that means person is not responding to calcium channel blockers, because if I say person is vasoreactivity test positive, that means that I need to give large amounts of calcium channel blockers to the patient. If vasoreactivity is present, you can give CCB, pulmonary artery will dilate, the pressure in the pulmonary artery will come down. But if I say vasoreactivity test is negative, that means initial drugs are not working, calcium channel blockers are not working. He is already grade 2, right? Class 2. You see, you can remember class 2 similar to, I would say, akin to New York Association grading for dyspnea. So let's try to make this simpler. You have a patient of pulmonary artery hypertension who says, doctor, when I used to climb stairs, I used to feel breathless. Now even going to bathroom is a big deal for me. So if he says like this, going to the bathroom is big deal for me, I actually really do not need to go into this vasoreactivity test. I know that he's deteriorating. So I need to go for the next step, that is start this patient on either ambrisentan or busentan. And that would be definitely the answer to this question. I mean, why the answer is not prostaglandins for management of this patient? Then we do not use prostaglandin IV alprostadil, because alprostadil is what we used in tetralogy fallat or tricuspid atresia or interrupted aortic arch in congenital heart disease. I've explained. You would be left between A and B. So suppose in the exam in the coming months he gives you class 3 and he says that now the same chap is saying, sir, even sitting on a chair, forget about going to bathroom, even when I'm sitting on a chair like you are at the moment, I'm feeling so breathless, then I need to upgrade to prostaglandin, so I might have to go for an infusion of epoprostinol for the patient, or even use eloprost. So prostaglandins are gonna come subsequently if he's gonna be deteriorating from, let me say, class 3 to class 4. But at the moment he just tried to make the question look very sophisticated. Question was very simple, straightforward. Class 2 pulmonary artery hypertension is not improving, what will you do? Upgrade the treatment. Upgrading the treatment means start the person on ambrisentan. The subsequent question said, what is the maximum flow rate for conventional oxygen therapy? The word is caught. You see, if they use conventional oxygen mask, it's gonna be 10 to 12, but if they say conventional oxygen therapy, then it would be 15 liters per minute. The answer to this question is fact-based data, option number D. The subsequent question talks about a 65-year-old man who comes to the OPD after a history of fall. Now he is hypertensive, he has atrial fibrillation, and is on a large number of medications. Let's read the names: captopril, atenolol, aspirin, and amiodarone. And the image given was of a person who was having hyperpigmentation, literally a blue person with hyperpigmentation over the tip of the nose, over the cheeks, and even around the lips. And the question says, which of the following would be responsible? So you very well know hyperpigmentation is a common problem with the antiarrhythmic drug, and this antiarrhythmic drug is useful for rhythm control in atrial fibrillation. I have explained the fact that amiodarone is a broad spectrum antiarrhythmic which is useful for both ventricular as well as for atrial abnormalities, that is both for management of ventricular tachycardia as well as for rhythm control in atrial fibrillation. And this time we talked about a side effect of this chap, so the answer would be option number C. The subsequent question said, which of the following is correct about hepatocellular carcinoma? Option A said global incidence is rising, so I thought I'll just show you a reference from Harrison for the same. He has just picked up this particular question line by line from Harrison volume 1, hepatocellular carcinoma, initial few paragraphs. You can see he says liver cancer is the 6th most important cancer worldwide, and the incidence of this and even the death rate with this is steadily increasing. I mean, normally with improvement in diagnostic rates, we are able to decrease the death rates for various cancer. But currently for liver cancer, we are finding both the death rates and even the incidence has been rising because we are able to detect it. But when it comes to, I would say, early detection, then definitely we are still lacking in, I would say, as compared to the demand. I would say the availability of early diagnosis is still lesser. It's limited to mainly developing countries. So the cancer of this burden is definitely increasing. This looks like a okay statement. Then is NASH and NAFLD being responsible for hepatocellular carcinoma. It is important for me to show a reference here because you see for hepatocellular carcinoma, the first impression is hepatitis C and hepatitis B, obviously hepatitis C leading it. But then studies have shown that even metabolic syndrome, even NASH and NAFLD are responsible. Even obesity is one of the risk factors for development of, in the long run, because of hepatic steatosis, hepatocellular carcinoma. That means the problem would be somewhere in the therapeutics, that is option number C and D. Lenvatinib is given for tumor size less than 3 centimeters. So let's look at this table from Harrison, where is mentioned that if a person is having nodules and the size of these nodules in the liver is less than 3 centimeter, then in these circumstances, I mean, what are you going to do for the patient? You're going to go in for a chemoembolization. On the other hand, if you're gonna be having an advanced cancer where there's gonna be multilobular cancer, or let me say if there's a portal invasion, if there's a portal vein invasion, we will be going in for drugs that is like sorafenib or lenvatinib for the patient. So you can very well see that at an early stage of detection, it is a chemoembolization which will be used. Now, based on this information, I'll say that again, if it's gonna be small nodule 3 centimeter, I would prefer a chemoembolization. Let's read option number C again. He says lenvatinib is useful for tumor size less than 3 centimeter. This is a wrong statement. Why wrong? Because the treatment at the point is chemoembolization. So in C and D, they have just, I would say inverted the data. So option number C definitely at the face value is a wrong statement. Then let's look at option number D. TACE is useful for management of a multinodular cancer. Then yes, I mean, usually we will find that the nodule can be single, but it can be more than one nodule also. It could be more, it could be 2, it could be 3, it could be 4 nodules. You will notice that even when it is multinodular, he has mentioned chemoembolization can be used. But if he specifies the word advanced stage of hepatocellular carcinoma characterized by portal vein invasion, then it is mainly drugs which are to be used. The logic is when it's really advanced portal vein invasion, going for a usage of monoclonal antibody based drugs. But if it's gonna be a nodular lesion, single lesion or multiple lesions, it is chemoembolization. So option number C definitely is a correct statement. There are 3 correct statements here. So option number A, B and D would be the correct statements for this question. And subsequently, I mean, this was a multiple response type. So I've just told you logically that what are the correct and which are the wrong ones. And because treatment of hepatocellular carcinoma is something that even in surgery, they tend to focus more on the etiology behind it and the associated factors, I would suggest you to just take a snapshot of this table. And if you just get the basic facts right, especially with respect to when would you like to go in for chemoembolization, that's going to be the situation. If you just get a visual memory of this, it could be a single nodule less than 3 centimeter or even multinodular. You can still go for chemoembolization for the patient, which justifies option number delta, a relatively a difficult one, I would say. The next question said, which of the following is useful for treatment of both seizures as well as neuropathic pain? So you would have seen so many patients of sciatica and post prolapsed intervertebral disc where you would be giving gabapentin, carbamazepine, or instead of gabapentin, like you could be using pregabalin. So he is just asking you to select which are the correct options in this case. That would be option number A, C and D definitely fit the bill in this case. The next question said splenomegaly is not a feature of. So we very well know organomegaly is a feature of all leukemias, CML, CLL, hairy cell leukemia. You can solve this question even as odd man out because there are 3 leukemias and 1 non-leukemic condition. So the answer for this would be aplastic anemia, where there would be a defective bone marrow because of which there would be a pancytopenia, but organomegaly is not present. The next question talks about a 60-year-old female who has reached menopause at the age of 52 years and has had a Colles fracture. DEXA score is definitely very, very less. So considering the age of menopause of 52 and a T-score of -2.5, we would be using bisphosphonates for management of these patients. Yes, hormone replacement therapy is one close option, but I can say that I would let the obstetrician talk about the hormonal replacement therapy and its side effects. The first answer for this patient, considering that she has already sustained a fracture, considering that her menopause is, I would say, a little on the delayed side and she is having a very low T-score, the first treatment where we can hope that we can upgrade from 2.5 to 2.4 to 2.3. I'm not saying a very dramatic increase, but some improvement in bone mass can be seen with alendrolate, though this again has been disputed in a couple of studies. Some studies say whatever you do in osteoporosis, bone mass that is lost is permanently gone. I mean, you cannot do anything to reverse it. But then still some studies say that, okay, bisphosphonates will help in at least preventing further deterioration and in some cases even an improvement in the bone densitometry. Coming to the next question, he's talking about a 62-year-old patient who's admitted in a heart failure ward and is scheduled for a heart transplantation. His kidney function test is also deranged, primarily cardiorenal syndrome, because ultimately if the heart will fail, the perfusion of the kidneys will also be affected. Hemoglobin is only 6 gram%, which can be explained with the cardiorenal component that I said, that if it's going to be, let me say, ischemic cardiomyopathy, then the perfusion of the kidneys would also be affected. He has developed CKD. The kidney damage means erythropoietin production is lesser and therefore hemoglobin is in severe anemia range. The physician has ordered 2 units of whole blood, and you can very well understand if you give 2 units of whole blood to a guy who's having severe anemia, who's already in compensated heart failure, now will develop decompensation. You have seen that post the transfusion, just within the 4-hour interval, this chap is having respiratory distress, might be feeling feverish, and mean arterial pressure is grossly elevated. So all these features, especially respiratory distress with elevated mean arterial pressure, is in favor of circulatory overload in this patient. That would be TACO. As compared to trolley, why I'm saying is because MAP is elevated in this person, and moreover I can say it was whole blood that was given. I mean, I would have been still speculative and in favor of trolley if it was packed RBCs, because he's already having a compensated CHF and you gonna give whole blood, this will definitely deteriorate. So I'm gonna go in for a chest x-ray, yes, because that will show cardiogenic pulmonary edema. And I'm also gonna go in for BNP levels, though a lot of guys were like, already sir is in heart failure, what is the point of BNP? But the point is, in evidence-based medicine, agreed that you are saying that you have admitted somebody for a heart transplantation is deteriorating further. If the cardiac output is decreasing, either do a echocardiography to demonstrate that okay, the ejection fraction is lesser, or have evidence of the BNP values. I mean, let me say the BNP values show a doubling or a tripling. That means this guy is deteriorating and you need to act fast or intervene fast. So the logic of doing BNP values in a chap who's already in heart failure is just to demonstrate the quick deterioration that is occurring in this patient, which means A and B are the correct options for this question. And I think that there were 2 questions on TACO. So one I would let the pathologist discuss, and you can go to the pathology section for covering another question on TACO that was asked. But most of the time I would say that when it comes to trolley versus TACO, they love to ask about investigations that would be useful for working up a diagnosis. Obviously X-ray, echocardiography, BNP, mean arterial pressures, JVP definitely will help. But when it comes to WBC count and leukocyte antibodies, you can see in the table that I'm showing before you that in trolley we can be having a leukopenia and leukocyte antibodies that may be detected, but there is no rule of diagnosis of white blood cell count and leukocyte antibodies or any CD marker that also some people said is not useful for convincing, or rather I would say to highlight the diagnosis of TACO in the patient. The subsequent question talked about a 70-year-old man who's having a pallor with cervical lymphadenopathy and there's bruises over the body. So I'm having 3 things: pallor, I'm having bleed, and I'm having organomegaly. So I'm thinking in terms of possibility of any kind of a lymphoreticular malignancy in a 70-year-old man. The key word in the MCQ was presence of smudge cells, which is gonna definitely make the diagnosis as chronic lymphocytic leukemia. And he says which of the following is best for diagnosis. So what we're gonna go in for in this particular case is definitely a flow cytometry, and the report is gonna be written like this: CD19 positive, CD20, and CD23. And the highlight will be presence of CD5. I mean, you very well know that CD5 is expressed on a T cell, but CLL is one blood cancer, which is a B cell tumor that expresses a T cell marker. So this becomes relatively easy to identify, and we can diagnose CLL or even on peripheral blood. If you listen to the discussion of CLL, I've highlighted the investigational choices, flow cytometry, and not a bone marrow per se, primarily because bone marrow you are not going to quantify. And why not a fish? Because there are so many chromosomal abnormalities related to CLL. It could be 17p. I mean, it could be, let me just write down the chromosomal associations. You can have a trisomy 12. You could be having defects related to chromosome number 13. It could be defects related to chromosome number 17. In fact, 17 is itself a question. Which chromosomal defect has worst prognosis with CLL? That's defect in 17 chromosome. So the point is, because there are so many defects, you just can't identify. Unlike in CML, where okay, there can be like only a single Philadelphia chromosome coming into the picture, unless and until it is a atypical CML. In atypical CML, I'm very sure, I'm saying it fast, but atypical CML, listen to the CML video. Atypical CML is related to defect on chromosome 20, whereas obviously CML is related to Philadelphia 9s to 22 swap. The next question was again based on values. He said which of the following is a wrong statement about heart failure. Mortality in a case of heart failure with reduced ejection fraction is about 40%. In a chap with preserved ejection fraction is 15%. And some people said, sir, they made this statement even longer by introducing non-cardiovascular mortality versus a cardiovascular mortality. But the bottom line is, if you look at a chap with reduced ejection fraction, the definition of reduced ejection fraction would be ejection fraction less than 40%. If you look at this cutoff of preserved ejection fraction, it would mean ejection fraction not normal, it would mean something in the range of at least 50%. So what I'm saying is that there's only a difference of 10 points only. No? I say ejection fraction 40%, ejection fraction 50%. Point is, it's only a 10-point difference, and this 10-point difference or 10 percentage point difference really does not affect the mortality very significantly. I mean, people with heart failure, the 5-year mortality rate can be more than 50%. Option number B is definitely a correct statement. Chances of death are definitely higher, and I'll just show you Harrison reference for this also. He says as much as 60 to 70% of patients can actually die within 5 years of diagnosis when they're suffering from heart failure. And when it comes to the current data, he has mentioned that the all-cause mortality was not sufficiently different. He said because after all, just give you values. No, for a reduced ejection fraction, it's gonna be 40%. For preserved, is gonna be 50%. So not too much of point difference, I would say, to make a significant impact on the mortality. So I would say that this statement looks like a wrong statement. Why? Because it is written in reduced ejection fraction. If you go by English, A will look okay. I mean, when you say reduced ejection fraction versus preserved ejection fraction, if you go by English, reduced ejection fraction, the thought process is less chances of survival. But I said don't go by English in this case because the difference is very limited. But B is definitely correct statement. Atrial fibrillation is a leading cause of embolic stroke. I mean, that's very correct to state, especially non-rheumatic atrial fibrillation is the #1 cause of development of embolic stroke. ACE inhibitors leads to angioedema and dry cough. I checked this even in pharmacology books. This data is fine. Angioedema 1%, dry cough is something in the range of about 10 to 15% in most of the books. So if you look at the information provided, I would say 3 correct statements and 1 wrong statement is present. The answer to this question would be option number alpha. Coming to the next question, which I think has been extremely twisted in the recall. So let me just read it out before you so that we can have a feel of what actually was asked. 25-year-old female presents with palpitations and feeling febrile all the time with a visible neck swelling. And the moment a surgeon is going to read a visible neck swelling there, straight away going to assume that he's going to talk, he may be talking about, maybe a multinodular goiter. Now I'll tell you why this was not a multinodular goiter. Listen to the description. I had a chat with a lot of guys who said, the question said on palpation or diffusely enlarged thyroid is felt. Now you can argue, sir, even in multinodular goiter, there's a possibility sometimes in a toxic nodular goiter that it might be still having a diffuse enlargement initially. Later on, one of the nodules might grow faster than the other. So what's the big deal about it? He says the fact that the lower border of the swelling is seen moving with deglutition. That's okay again for a thyroid mass. So point is, this can be Graves' disease. This may not be Graves' disease. I agree. But do you get exophthalmos in conditions where there is overactivity of the thyroid gland, but Graves is not present? See, the point is exophthalmos, diffuse enlargement of the thyroid gland, and obviously a young female with sympathomimetic symptoms, they all point towards clinical diagnosis of Graves. And this is what Harrison says: for diagnosis of Graves, which is straightforward, you just need a biochemically confirmed thyrotoxicosis, the presence of diffuse goiter on palpation, ophthalmopathy, and if possible a family history of autoimmune disorders helps in a diagnosis. He says patients who lack these features, listen to these words carefully, only patients who lack the features that I've said, I mean there is no diffuse goiter on palpation, there is no ophthalmopathy, there is no biochemical determination made very clearly, then it is a thyroid scan which is to be done in the patient. So in surgery, when they've discussed this question, they have thought it to be isolated thyroid swelling, and they have even talked about an FNAC. But my diagnosis of this case is Graves. In Graves, we do not go in for an FNAC. So I'm ruling out option number C. I am ruling out thyroid scan because the first line, see, questions are made from textbooks. Questions are not just created as a case. They have to, after all, give a reference also. This is the reference of mine from Harrison. So if you're going to treat it as a thyroid mass, if you're going to treat it as a multinodular goiter, then okay, I mean thyroid assay and ultrasound and even a thyroid scan. Option number A, B and D will make sense. And I think most of surgeons would have talked about option number A, B and D. And I'm very sure you would ping me here and says the surgeon has given a different answer. Why? Because he has made a different diagnosis. When you say, if I remove exophthalmos from this question, If I remove the word diffusely enlarged thyroid, if I just say enlarged thyroid is visualized or is palpated by the surgeon or physician, there is no exophthalmos, age group, let me say increase to 50 years of age, then okay, I mean option number A, B, C, D, all would make sense. But considering that we are saying this is a young female with the statements that I've highlighted, the first line, and I spoke to people who I would say would be specializing in endocrinology also. So they were very particular about the statement of Harrison that this is definitely one of the clinical dictum and the rules which is to be followed. So the correct answer for this question is option number A. Mind it, if I remove certain words there, I'll just highlight them once again. If in this MCQ diffuse word is not given, exophthalmos is not given, young female is not given, then you definitely can be answering even A, B, and D, and even A, B, C, and right, because if it's gonna be a solitary nodule, ultimately, if I find on a thyroid scan it's gonna be a cold nodule, I might have to go in for a FNAC in the patient also. Now coming to the last question of this discussion, I could have left it for the pathologist, but it has a medicine overlap because he's talking about which structure is involved in the commonest subtype of GBS. So you will notice that in Guillain-Barré syndrome, I've talked about AIDP, that is acute inflammatory demyelinating polyneuropathy, and therefore the damage would be in the myelin, because we also have subtypes present, like we have AMAN, acute motor axonal neuropathy, we have AMSAN, acute motor sensory axonal neuropathy, and obviously the damage there is in the axon. So what is mentioned as option number A here is definitely the axon, which is bang in the middle. Then you can see marking at option number B, and this option at marking at area number B is the one that would be the answer to our question, because this is where the myelin would be specifically present. So let's look at option number C, that would be the basal lamina. And then option number D, that if you look at, I can say that this would be the Schwann cells which would be present in the periphery. So considering the fact that if this question said Aman or Amsan, then I would have answered as option number A. But considering the fact that they specifically mentioned commonest type of GBS, that is AIDP, the answer should be given as the concentric lining that was present. The image may not be exact, but it was a similar kind of image that was given where the concentric lining of the myelin could have been visualized. The argument of yours will be obviously, sir, at a UG level, how do they expect us to interpret a electron microscopy image? I definitely agree to that, but at the same time, I mean, if you are try and guess out this question, it can be worked out, because myelin would anyway be concentric and would not be present bang in the middle. I mean, that's where the axon would be present. Slightly difficult one in a sense that you had to anyway rule out the presence of the Schwann cells, the basal lamina, and you can work out the diagnosis for this question. So these are the details, guys, that I would like you to remember for today. Keep the focus on, keep on doing questions on regular basis. And in fact, it's always a good idea in any set to work it out retrospectively, because lots of time questions can be repeated with slight tweaking. And it's just that you have to identify and realize that slight tweaking in the options that might have been made. So keep the learning process on. Thank you for your patience and hearing me out.